panel of speakers here to lead us in a discussion about how the financial inclusion sector, that's all of us, can strengthen primary healthcare delivery and really help develop resilient communities. So I have three panelists. They're all deeply engaged in the intersection of financial inclusion with health and well-being from three very different vantage points. First of all, I'd like to welcome Annie Wang, Head of Global Health at Opportunity International. Annie oversees the integration of health programs across our network with inclusive finance partners in Africa, Asia, and Latin America. Secondly, a warm welcome to Olga Bioska, Professor of Economics at the Yunus Centre for Social Business and Health at the Glasgow Caledonian University. And Olga leads the Economics of Health and Wellbeing Research Group. And finally, I'd like to welcome Morcheda Chowdhury. Morcheda is the former Director of Health at BRAC, where she led the world's most extensive community healthcare network. I think due to time, we'll jump straight into the conversation, but please do engage with us. If you have any questions or comments for our panelists, send those in, and we will have time at the end for a very short discussion. Annie, perhaps my first question to you. For those who've joined us, could you maybe outline what we mean by untapped potential? Where do you see financial inclusion being able to tackle primary care at the last mile?
Sure. Thanks so much for the intro, Deb. So I think, first of all, microfinance and financial inclusion is not a new sector. And even actually the integration of social services through microfinance networks is also not new. We've seen, this whole generation, if you will, of innovations in the sphere, particularly in the early 2000s. And then as the sector became much more commercialized, much more regulated, a lot more bankers on boards, you saw that really kind of a segmentation within the market. And while there were still innovators, some adopters, largely the sector fell into the laggards where it wasn't really seen as core, to businesses, to financial service offerings. But COVID was a real inflection point. And with that inflection point, we've probably a bit overused, but as an inflection point for this particular sector, what was really clear is that the business of these financial institutions hinge on the resilience and the health of their clients. For a woman living in poverty, her health is her greatest asset. And so in terms of the untapped opportunity, in a way, similar to, I think, a Gates Foundation report earlier this year, it's almost like the second boom. What do we think now about the global health sector and the intersection of that with the financial inclusion sector? There are so many different opportunities. I think today I'm excited to be talking about a couple of them. And the one that really stuck with me was what happened during our COVID response. So as Opportunity, we work through financial inclusion partners. And during COVID, over about a 2-year time frame, we managed to facilitate vaccinations of over 6.4 million people in India and in South Asia. So in that initiative, when I went to the field to visit, what really struck me as kind of a global health professional by training was we often see people through the lens of a patient, a case, a client. But seeing this woman in a pink sari waiting to get her COVID vaccination, she held on so tightly to actually her loan card. And when I went over to see, because I thought it was an identification card, it became really clear to me that, she had really big dreams for her life, for her family, for her future. And this vaccination, these health services help to enable that and to really think of people, again, not through the lens of a particular case of a disease or particularly just through a healthcare lens, but broader than that is much more empowering and is ultimately the untapped potential that we're here to discuss. So I think maybe I'll pass it on to Morcheda.
Thanks, Annie. I think, you powerfully said a woman living in poverty, health is her greatest asset, and that was a really powerful example from COVID. Thank you, Morcheda. Yes, let's move over to you from your unique perspective at BRAC. What's your opinion? What's that untapped potential where this sector can really step in to strengthen primary care delivery?
Yeah, thank you, Deborah, and thank you, Annie, for setting the stage. Yes, considering the resource scarcity and growing equity gaps, so there is no alternatives other than like service integration. And microfinance institutions are better positioned to do that, considering their reach in the community. And financial inclusion programs are increasingly reaching individuals who have been otherwise excluded due to social, economic, and geographic barriers. So these barriers prevent access to essential services like healthcare and other services as well. And they make communities more vulnerable to shocks. So in resource poor setting where governments often lack the infrastructure to prevent health shocks, focusing on prevention become crucial. So how MFIs can play a role in prevention? So if we see the current scenario, like many developing countries invest only a small portion of their health budgets in primary health care. According to the World Health Organization, less than 5% of health spending in low-income countries is directed towards primary health care, even though it's essential for building an effective community and centered health system. This chronic underinvestment limits the system's ability to provide necessary care, resulting in overwhelmed hospitals and clinics that struggle to manage life saving services. So, by strengthening local demand for preventive care, primary health care can be more effective, and microfinance is better positioned to do that with their outreach services. And they can use this network to offer first point of basic preventive care, instrumental for improving basic health knowledge and shape the health seeking behavior. So when MFIs provide both financial and health supports, they also build the trust within the community they serve. For instance, BRAC's network of 25,000 credit officers who visit 750,000 households or 3.2 million people daily offers health education and simple diagnostics, which helps detect health issues early, improve health outcomes, and reduce healthcare costs while improving trust in the integrated services. So I'll stop here and pass on to Olga.
Thanks, Mocheda. That's, just a reminder, I think, especially with BRAC, of that unique infrastructure that we can leverage to deliver health messages, as you say, but also perhaps run simple diagnostics. Olga, over to you. So I think both Annie and Mocheda touched a little bit on trust and on social capital. And maybe you could perhaps build on those two elements. Why are they so key from your perspective for health outcomes?
Yeah, thank you, Deborah. So I think trust is fundamental. I think the untapped potential is huge. So, and I think, the magic bullet that the financial inclusion sector has is actually the trust it can leverage for, if you want global health initiatives. And I think, Annie was talking about the vaccination campaign. That was, governments seeking ways of finding where the people were, the people that they couldn't reach because they do not receive primary care. They're in rural communities. This was, they saw this financial inclusion sector as a way to get to them. Why? Not only because, having your BRAC community health worker knock at your door, you're going to open that door because BRAC well, you trust them, you've been working with them for ages. They've created this community-based spirit. And you're going to trust them, and you're going to open the door, and you're going to listen to the advice. And if you need to get vaccinated, get vaccinated. So it not only opens the door towards participation and engagement with the healthcare system, but also impact, right? So keeping up with programs and keeping up with prescriptions, So I think trust is a fundamental way of doing it. And actually, the biggest thing here is that we've started measuring it, because it's not only us that are realizing there's this strong healthcare and financial inclusion thing. We're getting better at measuring it. For example, in the 60 decibels microfinance index report, last year they were saying how non-financial services were increasing the resilience of borrowers. And I think this year the results are even more evident and more clear. So I think trust is the key magical bullet for the financial inclusion sector to promote global health.
Thanks, Olga. I think that 20 years with opportunity, that really resonates for me. So that alongside access to finance and training, that strengthening of social relationships, of ties, of trust, particularly for women, is what really builds resilience. So thank you. And I really appreciate your comments on data and evidence, and we might come back to that in a second. Let's quickly move forward the conversation. And the potential is there, but how do we realize that potential? How do we scale? So I'd love you all to comment on what you see maybe as some promising new innovations that might help to reduce medical impoverishment and contribute to universal health coverage. Annie, how about some examples from you? Anything that you might inspire the sector with today?
Yeah, for sure. So definitely, I think the potential is around like trust, primary healthcare strengthening, but also around how we can be scalable and sustainable and have that really great impact in the community. So just in terms of, I guess, health financing is one avenue. We know that, as you mentioned in the beginning, over 1 billion people experience catastrophic health expenditure every year, 1 billion people. And I think it's about a third of that that's estimated to actually fall below the poverty line because of health expenses. And so the number one reason for loan default or a lost productivity more often for a borrower is a health issue, personal or in the family. There's a gendered aspect to this too, where, when someone falls sick, largely the caring responsibility falls to women in the household, also has implications for access to education for girls. But just looking at it from a financing perspective, when we experience these shocks, particularly when they're health shocks, the financial institution is really uniquely positioned to be able to help support its client and also support its business because it is so core. That resilience of, again, the client being so closely tied to the success and viability of that business. So we've seen a couple examples with health financing across like a multitude of different tools. And we know that that suite and that mix is what's really important. So across kind of the spectrum of savings, where we've seen quite a lot of exciting uptake, particularly around commitment savings, and then moving into more insurance products, voluntary as well as non-voluntary, and then moving into loans, which is sort of like the last tool that we want to use in the toolbox, starting off, of course, with government social services before we even get into health financing tools. But within that suite, what we've really found as opportunity is the importance of integrating access to care alongside access to finance. So as an example, one of our pilots in India around healthcare finance really shows the power of not only introducing like a maternity wallet or a hospice cash product, or whether it's access to any of these financing products, but also making sure that women are getting access to antenatal care, making sure that there's follow-ups and that there's adequate planning for birth, planning for maternal and child health services along the way. So I think what we've seen also interestingly is the integration of telemedicine alongside some of these financing products, or the integration of other primary care providers alongside financing. So it's almost like a bundled product where financing isn't just here's a loan, but financing is really about what is actually the need beyond the financial component. How do we think about it from a system strengthening perspective?
Thanks, Anna. Yeah, some really interesting examples of really how the sector can diversify product offerings beyond just income generating loans. So yeah, hopefully we'll have time to come into that. And Morsheda, could you share perhaps some examples from Bangladesh?
Yes, definitely. So I'll circle back to COVID-19 pandemic, when the whole vulnerabilities across multiple sectors were exposed. So what BRAC did with using the MFI network, BRAC responded swiftly, and it immediately mobilized its huge network of 100,000 outreach network, both MFI, health, and other sectors, and provided basic knowledge on prevention and home care regarding COVID-19. So the most effective method was using digital platform. And because at that time, reaching in person was difficult, so we were pushed to use this digital network, and it paid off. Within a couple of months, MFIs included 600,000 families into digital financial system, and through a digital wallet, each family received a cash transfer to meet basic needs. Later on, government also realized that this is a very effective platform, and BRAC and government also used that network and provided cash incentives to 5 million households. So that was a kind of real-time support that people need to meet their basic needs like food. And later on, the similar example can be cited when Ebola attack happened in 2014 in Liberia and Sierra Leone. So despite of 7-month suspension of operation, BRAC microfinance initiatives successfully resumed with 2 key strategies: maintaining community relationships even during the shutdown, and continuing essential services like health, education, agriculture programs. That means the continual support to the communities, which gave them the confidence, and then resume their work, microfinance work in that community. So these 2 incidences indicates that multi-sectoral collaboration can solve some of the accessibility issues and offer more equitable healthcare for mass population when there is emergency or emerging issues. So besides health literacy, MFI specifically can solve some health financing issues that Annie touched upon. So not only like health loans and micro health insurance, but other products like conditional loans and conditional loans for small scale agriculture, livestock, poultry, which is capable of addressing the nutrition gaps and improving supply and consumption. That also helps in building healthier community. Yeah.
Thanks, Mochia. The impact is transformational. So thank you for that example. Olga, you lead the Economics of Health and Wellbeing Research Group at the UNIS Centre. Maybe you could share with us, what are you seeing from your research? What's exciting? What's new? What should we be looking out for?
Thank you, Deborah. So it's a tough act to follow Mochia on this one, because she probably has the most innovative health finance institution. BRAC is absolutely amazing. So I think, innovation is crucial, but it happens a lot. It's a little bit what Annie was saying at the beginning. This is not new. These programs are not new. They're just more developed. They're different. And I think one of the things that we need to be really mindful of is how innovation happens, how innovation is being implemented, how we think about innovative programs, because what we are seeing now more than ever, particularly in research, is that same programs don't matter equally for everyone. So it's a matter of where, what, why, to whom, and the need for these innovations to be locally led has become more and more important in any innovation. And I'm a big fan of cervical cancer screening programs, partly because they're so difficult to implement for a lot of cultures and traditions. And I want to highlight too, they have more or less the same, the packages have more or less the same characteristics, the same parts of the programs. However, it depends a lot on how these programs are implemented and if they've been developed with the mindset of the people that are going to be using them. So for example, Crecer in Bolivia or Conserva in Mexico both have two things that make them really relevant and have made them really successful. One of them is they actually are really, really culturally appropriate. They take it really seriously. They know who, they're patient/client focused. That is the focus, and they are holistic in their approach. But also, they have been really smart, and this can only happen if you are adapting to a local context in how they create their partnerships. So it's not only private partnerships, which is very usual in the health financial inclusion remit, but also public partnerships involving bigger, more regional, more council, more national level, depending on the programs and who is being served/benefited by them. So I think the fact that they need to be locally led and that push for it is really, really important.
Thank you, Olga. That's a great reminder to the sector. And I'm here in Uganda. We're doing some market scoping for health finance, and I met a doctor yesterday who was re-emphasizing the point that you were making about cervical screening. Really, really important, so that these women are not ending up in the hospitals. Thank you for reminding us about that. We'll just have one more question and then we'll come to the Q&A. Everyone who's joined us today knows that we live in a world where competing challenges are really stretching government budgets. As I said, I'm in Uganda. There's 1.5 million refugees here. The government's dealing with climate change, a population, I think half the population is under the age of 15. And the world over, those challenges are only going to be increasing, but funding is finite. So with that challenge in mind, perhaps you could all tell us, where do you think we as a sector, as a financial inclusion sector, should be focusing our efforts to address the world's most pervasive health crises? Big question. Annie, could you kick us off, please?
Sure. I guess these are more thoughts, because I think to Olga's point earlier, it's not a new sector, but it is a sector, this kind of intersectoral approach of health and financial inclusion is sort of going through a revival, right? Like a kind of a second wave of sorts after the pandemic. And I think what we're seeing is that, well, first of all, with the SDG goals, we know that strengthening primary care is the most inclusive and cost-effective way to reach primary health goals, and particularly for SDGs, 75% of those gains, at least from a WHO perspective, can come from strengthening and accessing primary care. And so what I find interesting is that, we believe in order to achieve some of these very complicated goals, we have to start, again, with all the things we're talking about, community, with access, with primary care, focus on prevention, promotion, being grassroots-led. And yet, when we look at the split between the public and private sector, over half of primary care is actually delivered by the private sector. And this private sector is largely very fragmented, unregulated, lacks access to financing as well as capacity support. And as a global health community, we tend to focus a lot more on the public sector. And we don't necessarily think about, to Olga's perspective earlier, again, about that public-private partnership. What does the entirety of the primary sector look like? And how do we work within that rather than just looking at this limited space of just NGOs and governments, but really expanding the partnerships to be able to tackle these much more complex challenges.
Thanks, Danny. Mocheda, do you agree? Private sector partnerships, or what would you add?
Yeah, absolutely. And I would focus on the data sharing part, because obviously in terms of service sharing, it is essential to build on that. What is the gaps and where are the inefficiencies, and identifying that and making collaboration in those areas. So we know that public and private sectors are sitting on huge amount of data. So that could be the potential to use that data for making informed decisions, and that can guide targeted interventions and allocate resources more efficiently. So I think that this is still a very big gap, but this is a sector where we should look into to make more organizations more effective. And bigger organizations like BRAC already has started that process, like using its own data and also public and other private data to devise interventions that is targeted to solve that particular problem to that particular community. So I can give an example of another, again, COVID-19, because at that time we used the data from entire Bangladesh, and that is also collected by BRAC and also government data. So that gave us a indication that where are the most infections are lying and where infections are spreading. So interventions are devised in a way that prevention programs only targeted those areas which are at risk, because we have a scarcity of resources, human resource and financial, every sort of resources. And that really paid off to cut down the infection. Same example applies if we see that where the other diseases like chronic diseases are emerging, for example, hypertension, diabetes, cardiovascular diseases. So based on their data, the program can be devised so that we can do preventive intervention and also make the health systems more strengthened to provide services to that particular diseases. For example, in southern part of the Bangladesh, where salinity is an issue, that is also connected to cardiovascular disease and hypertension. So programs should be directed to preventive measures so that people should take less salt and do exercises or this kind of preventive measures that can prevent non-communicable diseases.
Thanks, Mocheda. Sorry to interrupt. We've just got a few minutes, so I might just jump over to Olga, and then hopefully we can come back to that. Thank you, Olga. Do you agree with Mocheda, with Annie? You have the financial inclusion section here. What's your call to action?
Thank you, Deborah. Absolutely, I agree with both of them. I'm going to be really quick. Funders, we need you, but not in terms of more funding, which of course we will. But it's not that. It's that. I think we're working in silos. In research, it's very, very clear that there's two silos. There's the financial inclusion silo and the health silo. And they are different. And it's very difficult for us to get funding. And I'm assuming for the professionals in the sector, it's exactly the same thing. To improve, funding for financial inclusion to improve health and vice versa. It's really complicated. And I think, we development funders have done amazingly in the latest years embedding all this intersectionality into their funding programs, with gender, with disability, with climate. And I'd advocate for a health intersectionality, because I think it's crucial. And we've realized during COVID, with all these examples that have been mentioned by Morshida, Annie, and many more than I'm sure people in the virtual room will be thinking about. I think that connection is really, really clear. So I'd ask from funders that, they have it in mind when they're funding these projects and when they're funding research programs or evaluations associated to them.
Thanks, Olga. Yeah, so the message, I think, is really clear: more funding, less work in silos, more intersectionality, as you say, and the power of partnership that came through very clear with Morshida and with Annie. Let's move on. We've got 5 minutes left. We'll engage the audience. We've had a question in. There might be time for one more, but Philip has asked, can documentation of participation by clients in preventative care be used to, for example, reduce repayments by clients? And I'm assuming, Philip, you mean things like risk-based pricing. Any comments from our panelists on that question from Philip?
I can start and other can jump in. I think, yes, so what we did, I can give an example. So what we have tried that to do the screening of all the clients before giving any loan, so that we know their health status. So if someone is at risk of non-communicable diseases, then he or she receives preventive education. But if someone is diagnosed with that, so he or she is, and all individuals are directed to micro health insurance. And nowadays it is becoming popular, because that helps, and especially people who have chronic diseases, because it helps them to access the healthcare and purchase the medicine. So I guess it helps to shape the healthcare utilization pattern, as well as give them a safeguard with the micro health insurance. So regarding repayment, it's not like repayment, but it secures their healthcare cost through like access to other products.
Great, thank you, Morshida. Annie, very briefly from you.
I think just building on what Morshida said, I think from a regulatory perspective, it's hard to kind of link the preventative health services to repayment. But what we have seen as a commitment from our financial institution partners who run health programs is that they're committing funding to the health programs. Like Morshida said, BRAC, of course, being quite an innovator in that category, but even a lot of our other partners, they're investing, after tax profit, they're investing CSR funds, they're starting foundations, they're looking at health as core to supporting their clients from a more holistic perspective, also so that they're able to compete more effectively against the fintechs and the inclusive fintechs that are encroaching in this space.
Thanks. Olga, any final comments from you on that question?
Yeah. So I've actually seen it from an innovator that failed, because this happens to innovators from time to time. But it wasn't in development. It was in a high-income country. It was in the UK, and they did it with gamification. So they got the clients to do different types of games, which weren't games. They were training programs on health, and they would lower the interest rates for the clients depending on the level of the game that the client had. So it could be done. I mean, there's lots of challenges with data, particularly like sharing data across the financial institution and the providers of the health services. But yes, absolutely. I think it'd be a good way forward if we find an ethic way of doing it.
Yeah. Thank you. Well, I think we're out of time for questions. We had a very short session. If you would like to hear more, then do reach out to our panelists. I think the contact details are on the site. But yeah, let me finish by thanking Annie, Morshida, Olga. Thank you all of you who've joined today as well. Thanks Financial Inclusion Week for organising the panel. As Morshida, as Annie and Olga have been saying, the needs are really great. We know that the challenges of ill health and poverty are closely interlinked. All of those who work for a financial institution will be very aware that the cost of out-of-pocket healthcare expenses can force someone to use up their lifetime savings or sell a livelihood asset. And we absolutely need to prevent them being pushed further into poverty. So what I'm encouraged by is the messages that have been shared today. The sector, as I know, is great at innovating. The challenge is big, but I think hopefully you get a sense of a message of hope from our panelists today, that if we work together in partnership, we can address some of those gaps in primary healthcare. So yeah, thank you all for joining us today. Any last words from Annie, Olga, or Mucheda as we're closing out?
Just a big thank you.
Thank you.
Thanks, everyone.
Thank you. And thank you, Deborah, for being an excellent moderator.
I should say I'm in near Nakia Valley refugee settlement, meeting some amazing refugees with phenomenal health needs. There is such a big market for health finance there. So I'm excited about what we could be doing in partnership to meet those needs. Primary healthcare, women's health particularly. It's crying out for this sector to engage. Thanks, everyone.